Sashikant sir. We conclude our morning scientific sessions with one of the most practically relevant topics in ACS management, antithrombotic therapy. Our own T. Sashikant sir, Senior Interventional Cardiologist at Yashoda, Secunderabad, will take us through the evidence on DAPT duration, de-escalation strategies, and how we balance ischemic protection with bleeding risk tools like ARC-HBR criteria and PRECISE-DAPT Score. Please welcome Dr. Sashikant sir.
Good afternoon, everyone. Sudhir said Raghu had given him an ambiguous topic. I selected a boring topic. And then it was pre-lunch, so it's more boring because it's hot food already ready outside the door. Jokes apart. Can this go a little height? It's too low for me.
Practically relevant, everyday problem.
Yeah.
Everyday gastroenterology reference.
True. So the topic which I chose and which Raghu gave me was antithrombotic therapy. What is the optimal duration of the dual antiplatelet therapy? How do we de-escalate? When should we de-escalate? To what drug should we de-escalate? And what is the bleeding risk? This is a very hot topic, a very much researched topic because the drugs are limited. Aspirin, Clopidogrel, Prasugrel, Ticagrelor. That's it. 4 drugs. But the number of combinations you have, the number of strategies you have to optimize the outcomes, the long-term outcomes and the short-term outcomes are very many. So we all know in patients with coronary artery disease, PCI is the cornerstone of treatment for those presenting with acute coronary syndrome. PCI, Percutaneous Intervention, is also a mainstay of treatment for patients who have a chronic coronary syndrome. So acute coronary syndrome and chronic coronary syndrome both are treated with Percutaneous Coronary Intervention. And here, the platelets play a very important role, a key role. Antithrombotic therapy, antiplatelets agents especially, play a pivotal role in optimizing outcomes in patients undergoing PTCA. The effects are both for acute results as well as the long-term results. In particular, the antiplatelet agents play a key role in prevention of both local and systemic thrombotic complications. Over the past three decades, there has been an evolution in antiplatelet treatment regimes that are being used in patients who are undergoing PCI. Also, the stent platforms, the technology, the technique has changed dramatically. We all are familiar with this one single slide which I want to, for all the medical fraternity to recapitulate. Platelets play a key role in the thrombus formation through adhesion, activation and aggravation of their initial tethering, which happens with the von Willebrand factor and the collagen which is exposed from the damaged endothelium, which is recognized by the platelet surface receptors, which are glycoprotein 2B receptors. And this activates the platelet for the release of certain cytokines, as well as activates the coagulation cascade, as well as the inflammatory molecules, and the triage of activating the platelet, activating the coagulation cascade and the inflammatory process leads to a thrombus formation which could be occlusive, sometimes semi-occlusive. Repeated episodes of these occlusive or semi-occlusive episodes lead to an inflammatory response in the vessel wall which leads to progression of atherosclerosis. And that is the reason why chronic coronary artery disease patients who have a borderline lesions should be on an antiplatelet agent, because disease progression is also modified by an antiplatelet agent. It's just not the statins, disease modifying drugs, but antiplatelet agents also play a role in preventing disease progression. So therefore, the rationale for the use of antiplatelet agents in patients with COPD, with CAD, is not only for the treatment of the acute thrombotic events, but also to modulate the progression of atherosclerotic disease. a very busy slide telling us the number of trials which are going on. I'm not going to dwell on each of them, but early 90s, when patients were getting aspirin and warfarin, those are the days I remember when we used to hold the groin, because femoral artery was the only procedure at that time. We used to hold the groin for long hours to prevent a hematoma or a bleeding. And with the bare metal stents, use of aspirin and warfarin all made it more difficult because stent thrombosis was an issue. In 1995, we started using ticlodipine as the first P2Y12 receptor antagonist. And subsequently, ticlodipine was withdrawn from the market because of its major impact on the bone marrow suppression. And Clopidogrel replaced the drug subsequently. And then we had the cure and the PCI cure study telling us about the advantage of P2Y12 receptors in combination with aspirin for the long-term and short-term management of acute coronary syndrome as well as chronic coronary syndrome in patients who have undergone a PTCA and a stenting. The initial PCI cure and the cure studies said the longer you use the dual antiplatelet therapy of aspirin and clopidogrel, the better the ischemic long-term results. So we started using these two drugs for a long-term to avoid stent thrombosis, also to give us a long-term benefit, because stopping the antiplatelets earlier than 1 year led to a stent thrombosis and a myocardial infarction. So we kept using these drugs for a longer and longer time, and these two studies established the role of dual antiplatelet therapy for a long-term use. Was it correct at the time? Yes, because aspirin was a sheet anchor therapy, and on top of that P2Y12 decrease the incidence of MI, stent thrombosis, and the cardiovascular outcomes, including stroke. So our initial goal for the first, from 1995 when ticlopidogrel was discovered till 2010 or 7 or 8, our initial goal was reducing our strategies for focusing on ischemic events. We said, let us reduce the ischemic events, let us hit them hard with the antiplatelet agents, reduce the ischemic events. But somewhere in 2006, once the drug-eluting stents started coming in, and we had the first generation of drug-eluting stents, Cypher and Taxus, where the restenosis was much less compared to the bare metal stents, we started seeing a storm of stent thrombosis. Every other patient or every third or fourth patient who was put on drug-eluting stent, once the DAPT was discontinued, they had a stent thrombosis. 2006, 2007, there was a red alert, a red flag raised by the American College of Cardiology and the European Society of Cardiology and said, beware, do not stop your antiplatelets prematurely. And that's where the concentration changed from giving these DAPT drugs for a longer time. By 2010, we observed the bleeding risk started increasing because we are using the DAPT drugs for a longer time. And that's where from 2010 onwards, we started looking at outcomes and said, okay, the ischemic outcomes are much better, but what about mortality? Mortality kept increasing. We are reducing ischemic events, but the mortality kept increasing. And that's where we found that bleeding is an important risk factor for cardiovascular mortality. And then we changed our strategy from focusing on ischemic event prevention to focusing on bleeding events. And then we started saying, okay, we established dual antiplatelet therapy for a long time, but is it okay to cut down the duration of antiplatelet therapy for a shorter time? Let's look at this example of this 83-year-old gentleman who came with NSTEMI. He has an atrial fibrillation and he's on Epixiban, 2.5 milligrams twice daily. He's a CKD stage 3B. His GFR is about 40. He has a prior GI bleeding and had a transfusion. He had a prior ischemic stroke. Quite a common situation what you come across day to day. His labs are quite okay. He has hemoglobin of 11. His creatinine is 2.3 and he has a rising troponin and he needs a PCI to the proximal LAD with a DES via the radial axis especially to reduce the bleeding events again. Now this is a high risk patient who has a very high risk of bleeding. In addition to the ischemic event what he had, there is a high risk of bleeding and a host of factors, predictors of bleeding. The age, he is 83 years old, he has CKD, he has anemia, he had a prior GI bleed with a need for transfusion, and multiple factors to predict bleeding. Of course, he has ischemia also. He has again the risk factors of his age, being extremes of age, he has a CKD, and he had a PVA telling you that he is a vascular patient who had a previous stroke and is likely to be prone for recurrent ischemic events, both cardiac as well as the brain stroke. So here is a gentleman who has a high risk for bleeding and he has a lot of host of risk factors. So what should be your strategy? The first step is risk assessment to guide the antiplatelet therapy among percutaneous coronary intervention patients. The first step is risk assessment. And how do we do the risk assessment? Based on the bleeding risk, you have a lot of clinical variables, the procedural features, and some bleeding risk scores. You have the ischemic risk, clinical variables again, procedural features again, and a lot of scores available. For the platelet responsiveness, you have a platelet function testing where you have a high platelet reactivity or a low platelet reactivity. You could also be doing a genetic testing to see if they have a CYP2C19 loss of function allele. So a host of factors are available to assess for bleeding risk, ischemic risk, and antiplatelet responsiveness. Based on these factors, one could make a decision, appropriate decision, how long to continue the dual antiplatelet therapy, how potent the P2Y12 receptor antagonist should be used. Should we use a Ticagrelor, Prasugrel, or should we use a Clopidogrel? Should we use a triple therapy combination with rivaroxaban, Ticagrelor, and aspirin? So multiple things could be assessed if was one done, a personalization of the antiplatelet strategies after PCI or before PCI, where one could study the various clinical features. For example, if somebody has a previous major bleeding, he has anemia, he has a reduced platelet count, he has a prior stroke, a severe liver disease, or he is quite frail individual, he has a high bleeding risk. Again, it is just not enough that you assess this, but also one needs to know what is the time frame of the events, what happens. If you have done a patient who has had an acute coronary syndrome and you have put him on a dual antiplatelet therapy, definitely by continuing the drug, you definitely reduce the local ischemic events of stent thrombosis. But this stent thrombosis has a time frame. If you have the initial 1 month, you have a high risk of stent thrombosis, but as time fades off, your risk of stent thrombosis or local ischemic events drastically reduce by 3 months. There is a significant reduction in the plaque progression and destabilization. Again, it stabilizes by about 3 months to 6 months there. And the prevention of systemic events like peripheral vascular disease or a cardioembolic stroke also is significantly reduced. What is important is the longer you use this drug, there's more of a bleeding risk, but very, very important, the bleeding risk continues to be there at the same rate till as long as you continue the drug. The ischemic events start dropping very drastically, but the bleeding risk continues to be at the same level. So are we justified in downgrading our dual antiplatelet therapy after 3 months because the ischemic events are much less, but the bleeding risk continues? So should we do that? So the time course of benefit and risk of antiplatelet therapy after PCI is very, very important. And at all these levels, we found that, we have to look at the bleeding risk scores. A lot of risk scores are available on the net. You just need to feed the data of the patient, PRECISE-DAPT study, and this is one of the academic research consortium bleeding risk protocol wherein you find at least one major criteria or at least two major criteria to tell an individual is at high risk. Or you could be using the European Society of Cardiology ischemic risk definition wherein you can have a high thrombotic risk, you have a diabetes mellitus, previous pre-MI, multivessel disease, polyvascular disease, whereas coronary artery disease and peripheral vascular disease, premature atherosclerosis in an individual less than 45 years of age, concomitant systemic inflammatory disease like SLE, rheumatoid arthritis or HIV, a CKD with a GFR of less than 15 to 60, multiple risk enhancers are present, and by this European Society of Cardiology risk enhancers, you can put them online and assess the bleeding risk for an individual with a PRECISE-DAPT score or DAPT score. Online scores are there, and you can classify the risk as high bleeding risk patient, where you could downgrade your treatment. The standard therapy by the European Society of Cardiology and by the American College of Cardiology, by the 2024 guidelines for chronic coronary syndrome, is continued dual antiplatelet therapy for 6 months for a chronic coronary syndrome. If he has had an acute coronary syndrome, acute MI or NSTEMI, standard DAPT duration should be 12 months. This is the standard of therapy what we have. But then we said this is increasing the bleeding risk, because the time frame for ischemic events start reducing significantly after 3 months. So we said, can we reduce the DAPT duration to 3 months, 6 months, or 9 months, or 1 month also? And there comes I think one slide which I wanted to keep just for you to understand the next consecutive slides. We measure the outcome of the clinical events, cardiovascular events, by doing a MACE, major adverse cardiovascular events. This captures the ischemic efficiency. You could have a 3-point MACE with CV death, non-fatal MI, non-fatal stroke. You could have a 4-point MACE, that is 3-point MACE with unstable angina hospitalization. You could have a 5-point MACE where there is a 4-point MACE with a heart failure hospitalization. So this is how we assess the ischemic efficiency of a drug, the major adverse cardiac events. But then there is a new terminology which all of you should be knowing probably, NACE. NACE is net adverse clinical events, wherein you have NACE means major adverse cardiac events plus major bleeding. And this is especially true for all the antiplatelet trials, all the antiplatelet drugs we do. It is just not reducing the ischemic events, it is reducing the bleeding events also, which converts into a cardiovascular mortality and morbidity and prolonged hospitalization. So what is important is NACE captures the net clinical benefit, the ischemic advantages and the negative risks of major bleeding. So it's a balance of ischemia versus bleeding which is captured by this terminology called NACE. So we started looking at a lot of trials. It's a very, very busy slide. We said, okay, can we cut down the short duration of dual antiplatelet therapy and de-escalate the therapy? So we said, okay, shall we give the drug for 1 to 3 months? I know it's very low here, there. 1 to 3 months duration. We have a host of trials. Shall we say give it for 1 month or 6 months? Dual antiplatelet therapy for 1 month versus 6 months. 3 months versus 12 months. 4 months versus 12 months. 6 months versus 12 months. So we said multiple trials have been done with various durations, and did we meet the primary endpoint? Yes, majority of the trials met the primary endpoint and said it definitely reduces the major adverse cardiac events, and also there is a benefit advantage of the NACE. The net adverse clinical events also were much, much better once we reduce the duration of antiplatelet therapy. So these are the various trials of the shorter dual antiplatelet therapy, the global leaders trial, which used Ticagrelor monotherapy for 1 month along with aspirin, and after 1 month it was only Ticagrelor after the PTCA. For standard, comparing with the standard DAPT of aspirin with Ticagrelor or aspirin with Clopidogrel for 12 months and then continuing only with aspirin after 1 year. Similarly, Twilight, the TICO and the TPAS, all of the trials which were done have very clearly shown that there is a reduction in MACE in almost all the trials. Not the global leaders trial, but most of the trials have clearly shown that the MACE is better, and the NACE, the net adverse cardiac events, the bleeding risk is much less when compared to the prolonged dual antiplatelet therapy, which is DAPT for more than 12 months. One of the trials, very important trials, is the Master DAPT trial, which was recently shown that the clinical outcomes at 12 months for about 4,434 patients at high bleeding risk. Now, mind you, this cohort had a high bleeding risk. Abbreviated DAPT for 1 month versus a standard therapy of 6 months clearly showed that the abbreviated DAPT therapy was not inferior to the standard DAPT therapy. There was no increase in NACE. There was no increase in major adverse cardiac events, and of course there was a decrease in the bleeding, the BARC type bleeding 2, 3 or 5, there was a superiority with the abbreviated DAPT. So based on this and the host HBR trial, again with about 1600 patients with high bleeding risk, 1 month DAPT with the 3 hours compared with the 3 months DAPT, this trial was showing that it was not non-inferior. However, the European Society of Cardiology gave a guideline and said, okay, in patients who have chronic coronary syndrome, in patients who have a high bleeding risk, you could shorten the duration of DAPT to 1 to 3 months. And in patients with high bleeding risk and ACS, where the standard of therapy is 12 months, you could abbreviate it to less than, or you could abbreviate it to 1 month and then continue with a monotherapy with aspirin or ticagrelor, probably ticagrelor. The clinical scenarios could be different. For a male patient with 62 years with an elective PCI needing a very short stent with no diabetes, no prior MI, no prior bleeding, no RL anticoagulation, single vessel disease, 1 short drug-eluting stent, he's a low-risk individual, and the 1 month DAPT trial has very clearly shown again that 1 month DAPT for non-complex lesions, clearly there was non-inferiority. Using a 1 month DAPT was equal to using a long-term 12 months of DAPT for these patients. So for non-complex lesions, you could shorten the duration of dual antiplatelet therapy to 1 month. And based on this, the European Society of Cardiology said 2024 guidelines, 1 month, especially in patients with high bleeding risk. In patients who have a non-complex lesion, again, you could use a 1 month drug. But in patients who have a non-high bleeding risk, non-high ischemic risk, you could shorten even in patients with chronic coronary syndrome to a 1 month DAPT followed by a monotherapy. This patient is different. A patient at high thrombotic risk but low bleeding risk, you're going to put a multiple stents in the left main, in the mid LAD, in the mid circumflex, and he has a prior MI, he has a diabetes, he has hypertension, he has a high thrombotic risk, and this individual probably would benefit with a long-term dual antiplatelet therapy. And multiple stents, bifurcation stents, left main stenting, triple vessel stenting, you need probably a long-term therapy. These are the individuals to have an extended risk, and they need they have an enhanced ischemic risk, so the duration of DAPT should be prolonged probably to more than 1 year, 2 years or 3 years. And in patients who have a acute coronary syndrome with moderate ischemic risk or residual ischemic lesions or a high ischemic risk, the duration of dual antiplatelet therapy should be quite prolonged. This is how we de-escalate. In patients who have, we have reduced from 12 months DAPT to 3 months DAPT or 1 month DAPT. In patients who need an escalation or a de-escalation, we have a certain strategy. So you could be doing a guided de-escalation or a guided escalation of the drug. You could be doing a platelet function test, which is measured by light transmission aggregometry, or a verify now or a flow cytometry, which is more sensitive, to see what is the platelet function, what is the platelet reactivity. If the platelet reactivity is high, probably you need to upgrade to a more potent antiplatelet drug like Ticagrelor or Prasugrel. But if the platelet reactivity is low, you could downgrade the treatment to a Clopidogrel. This is not a standard way of recommendation by the guidelines, by the major societies like European Society of Cardiology or American College of Cardiology, but on a patient-to-patient basis, one could assess the platelet function test to guide the selection of the antiplatelet therapy. Patients who are identified to have a Clopidogrel high platelet resistance or a CYP2C19 loss of function LLE on genetic testing. Now these are the individuals who are going to do badly on Clopidogrel continuing usage. They should be upgraded to a more potent P2Y12 receptor antagonist like Ticagrelor or Prasugrel. But not a standard of care. It's not recommended by the societies, but in certain situations when you have a very complex anatomy, high bleeding risk, as well as a complex anatomy and multiple stents, probably this is the way to go. So you could be doing a guided de-escalation or an unguided de-escalation. We have two trials, the TOPIC trial and the TALOS MI trial, which said uniform de-escalation. They didn't do a platelet testing. They didn't do any genetic study. They just said, okay, we are going to downgrade from by 1 month or 3 months of DAPT followed by a monotherapy. And they found it was okay it was non-inferior, there were no increased risk of ischemic events. They were a guided de-escalation also, where they studied platelet function studies, they studied the genotype by doing the genetic studies and found that high platelet reactivity or low platelet reactivity did make an influence on the decision making. There was a 26% reduction in the bleeding when they followed the genetic as well as the platelet reactivity studies. So the various studies which have shown the TALUS MI, uniform de-escalation, topic uniform de-escalation, tropical AS guided de-escalation with phenotype testing, with the genotype testing, Antarctic with a guided adjustment. Which was quite a favorable thing, saying that you could, without doing a genetic study or a platelet reactivity study, directly de-escalate these patients, and it is quite safe to de-escalate these drugs. What about P2Y12 monotherapy? P2Y12 monotherapy also is, again, a lot of studies have been done giving the monotherapy at PCI from the beginning, This is one neo mindset study which was done in published in 2025 in the European Society of Cardiology. On the go one, as soon as PCI was done, they started him only on Prasugrel, no aspirin. Aspirin was completely dropped from this trial, and they did it 1 month, they dropped aspirin. At 1 to 2 months they dropped aspirin. At 3 months they dropped aspirin. At 9 months or 12 months they dropped aspirin. A lot of studies were done. Again, there was a net benefit. If you did delete all the primary endpoint, most of the trials met the primary endpoint, and there was no increase in ischemic events except the neo mindset. Definitely there was an increase in stent thrombosis when aspirin was completely dropped from the percutaneous coronary intervention. So the European Society of Cardiology said single antiplatelet therapy, preferably a Y212 receptor inhibitor, should be considered in the acute coronary syndrome in patients who are event free 3 to 6 months after DAPT and who are not high ischemic risk. So after 3 to 6 months, you could switch over to a monotherapy with Ticagrelor or a Prasugrel and then see the same outcomes, ischemic outcomes and the bleeding outcomes. And the Ticagrelor monotherapy with 90 milligrams twice daily may be considered as an alternative to dual or other single antiplatelet therapy. Even the level of recommendation is 2BC. So for the trials of long-term Clopidogrel versus aspirin, okay, is Clopidogrel better in the long term or Ticagrelor better in the long term? The study was done, and in the host exam trial as well as the Smart Choice 3 trial, about 5,000 patients studied. They found when compared to aspirin, Clopidogrel in the long term, even up to 10 years of study, it has shown Clopidogrel to be superior to aspirin for reducing the ischemic events as well as decreasing the bleeding risk. Compared to aspirin, the Clopidogrel was found to be much better. Both these trials address the same core of question: is Clopidogrel safer or aspirin safer? Clopidogrel was found to be safer in the long-term usage of drug, both reducing the ischemic events as well as the bleeding events. So Clopidogrel 75 milligrams daily is recommended as a safe and effective alternative to aspirin monotherapy. Level of recommendation 1A, very strong level of recommendation there. We had some aspirin-free trials when they said within 1 week after starting the aspirin, in a patient who has a high bleeding risk, they stopped the aspirin, continued P2Y12 receptor monotherapy, and they did not find any major increase in cardiovascular events except for the trial which is the new mindset, which definitely showed there was a slightly increased risk of bleeding as well as increased risk of stent thrombosis. Is there a case for triple therapy? Yes. You have lots of situations wherein you have found a large thrombus burden, an LV clot, or the patient is having atrial fibrillation or a mechanical heart valve. These patients also need anticoagulation, either a neuroanticoagulation agent like apixaban or rivaroxaban, or even a warfarin as the anticoagulant. In these situations, yes, you need to give abbreviated oral anticoagulation therapy with P2Y12 receptor antagonist, preferably Clopidogrel plus aspirin for a short duration of up to 1 week, and then change over to an OAC with the P2Y12 receptor inhibitor. So you have a situation wherein you have to use as short a drug as possible. Triple therapy especially for 1 week, triple therapy for 1 month, triple therapy for 3 months, and then get the advantage of these drugs, reducing the bleeding risk, improving the ischemic outcomes. One size fits all doesn't exist. It has to be tailored. Antithrombotic therapy after PCI must be individualized, balancing the thrombotic and bleeding risks across the clinical profiles, high bleeding risk profile, high ischemic profile. Short DAPT followed by monotherapy is safe in high bleeding risk patients and is now endorsed by the major guidelines. P2Y12 inhibitor monotherapy is a valid alternative to aspirin early after DAPT discontinuation and even in the chronic phase. So I think with this, I would stop my presentation. We can have some questions if it's not too late for the lunchtime. Yes, we have to de-escalate from Ticagrelor or Prasugrel to Clopidogrel. And if you are using warfarin, you need to keep the INR in the low normal range, that is low therapeutic range 2 to 2.5. So we do reduce, if the patient is already on the DOAC and you have done a primary PCI or done a PTCA, we do de-escalate from a potent P2Y12 inhibitor like Ticagrelor or Prasugrel to Clopidogrel. If you are using a triple drugs, Clopidogrel is the drug of choice.
Because there was some discussion and they said that it is okay to continue Ticagrelor.
It is okay to continue if your patient is having a low bleeding risk. If you have a low bleeding risk, you could continue. But if his patient is having a high bleeding risk or his bleeding risk is not known or you have not done the DAPT score analysis or the PRECISE-DAPT score analysis or the ARC recommendations, then probably there is a role for de-escalating from Prasugrel to Clopidogrel.
So I have one practical doubt which I faced in last week. So in a ACS patient who has a high ischemic risk and low bleeding risk, who has been undergone PCI, presented after 1 year, DAPT score is less. How long should I continue DAPT, sir? We know it's prolonged DAPT is recommended. How long is it? Is there any recommendations for that, sir? Can you please give?
Yeah. So the PCI cure study and the cure study have shown that the role of antiplatelet agents, I mentioned in one of my first slides, the role of antiplatelet agents is just not reducing the thrombotic stent events. It is also being given for reducing the progression of plaque, a progression of atherosclerotic disease. Antiplatelet agents reduce the coagulation cascade and also the inflammatory process which is happening in the vessel wall. So by both ways, disease progression also is reduced. So if you have a patient who is low bleeding risk, continuing the drug for 2 to 3 years is okay. The PEGASUS trial and the PCIQ trial both have said continuing DAPT for 2 to 3 years is okay because it also impacts plaque disease progression. Yeah.
PEGASUS TIMI52 is the trial which showed evidence for the reduced dose of Ticagrelor, 60 mg.
60 mg Ticagrelor.
But along with aspirin.
Along with
a lot
aspirin.
of people tend to stop aspirin, but it's with both.
Yeah, along with aspirin, PEGASUS has shown that along with a reduced dose of Ticagrelor, 60 mg twice daily, with aspirin, or even Clopidogrel with aspirin for a duration of 2 to 3 years, if the patient is having a low bleeding risk, it reduces the local thrombotic stent events, also reduces the plaque progression.
Sir, if a patient is on silastazole for peripheral artery disease, then that should alter our choice of P2Y12 inhibitor, or we can continue with the same potent P2?
We do give in some situations silastazole, but the evidence is much more stronger for rivaroxaban at a lower dose. We have the COMPASS trial wherein you have a polyvascular disease, peripheral vascular disease, we have a carotid artery disease, we have a coronary artery disease. In that situation, dual pathway inhibition with rivaroxaban 2.5 milligrams twice daily with your P2Y12 aspirin. Yes, with aspirin. Or a Clopidogrel also. You can use Clopidogrel also. But majority is aspirin. So when you use a dual pathway inhibition, it is rivaroxaban 2.5 milligrams BD is better than your silastazole.
So if that patient undergoes coronary stenting, then what will be our choice of antiplatelets?
So for the first 1 month, you could use all the 3 drugs. 1 week or 1 month. 1 week or 1 month, you could use all the 3 drugs. After that, you need to come down to the DOAC plus aspirin or DOAC plus Clopidogrel.
Because here rivaroxaban we are giving not like a therapeutic dose for DVT, no sir. We will be giving only 2.5 mg BD.
Yes.
So will that be enough with single antiplatelet, sir? Because
So the purpose of the 2.5 milligrams twice daily is thrombin inhibition. It is not for the not for preventing a clot as such, but it's for thrombin inhibition, which also helps in progression of the atherosclerotic cardiovascular disease. Yeah.
I misled you, sorry. I have to correct myself. When we give this for PAD, our DAPT should be enough for the PAD also,
Yes.
peripheral arterial disease.
Yes.
You need not give the third antiplatelet for the
Exactly.
PAD.
2 drugs.
I misled. Then after 1 year, if we want to do as a chronic therapy, in the COMPASS you give a single antiplatelet plus rivaroxaban 2.5 BD.
Aspirin with 2.5 milligrams twice daily of rivaroxaban.
After 1 year.
After 1 year.
Yeah, I misled you, sorry.
How often do you see clopidogrel resistance
Okay.
in Indian subcon?
Yeah. So it's to the tune of almost 20%. Some of the studies have said 30%. There has been a, but it's not just doing the tests what I have shown. So each of the tests has got a different sensitivity and specificity. The most sensitive test is the flow cytometry, which is rarely done. It's done mostly in research. The light transmission aggregometry and the Verify now are the 2 tests which are available. You can do an instant study. Bedside you can do a study and you can get the result within 24 hours. Prior to your PCI, to know is Clopidogrel the best drug or you need to go to a potent P2 vital receptor antagonist. You could do a genetic testing also as fast as possible. Today in 24 hours you can do a genetic testing to see for CYP2C19 loss of function LLE, and you can get the result in 24 hours from the genetic one and say, okay, if this function has got a high platelet reactivity and he has a loss of CYP2C19 function, then probably straight away he needs to go to a Ticagrelor as a monotherapy, 90 milligrams twice daily, or on the long term 60 milligrams twice daily. It is seen in 15 to 20% of the patients.
Short DAPT is 1 month.
It could be 1 month, it could be 3 months. It could be 1 week also. It could be 1 week also if you have a high bleeding risk.
The post-exam results and the high incidence of clopidogrel resistance in our country, what do you suggest?
Yeah, with the host has had 2 studies. Host exam has got 2 studies. And for a patient who has a high bleeding risk, and if he has a clopidogrel resistance, probably the safer drug is Ticagrelor, not Prasugrel.
So what I'm saying is the long term.
Long term, the jury is not out yet, and probably you should weigh the risks and the benefits of a high bleeding risk versus an ischemic risk, multiple stents, complex stenting and all that. I think it's on an individual basis, case to case basis. You cannot fix a duration for a long term. But monotherapy, definitely yes.
But with our old prescriptions everywhere, nobody, all the trials are towards de-escalate. But in India, we face the risk of too much DAPT.
Agreed. Very much. In fact, without coronary artery disease also, we see patients with aspirin and clopidogrel.
Thank you, sir. Now can we have Raghu sir to facilitate Sashikant sir, please? Now